Netcast, are you ready for live? From Netcast, are you ready for live now? Can we start?
Yeah. Give us 1 minute. Yeah, we are live.
Yeah, okay. So, good evening to all the respected doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I, Avdesh Gupta, welcome our eminent doctor who have joined us for today panel discussion titled Views on Vildagliptin. At Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in the challenging time also. To help us navigate through the meeting, we have with us today Dr. Anis Bell sir, who is very big name, known name in the Karnataka and periphery at the entire national state, who will be our moderator for today's panel discussion. We take this opportunity to welcome our moderator for the day, Dr. Anis Bell sir. Also, I would like to introduce to our respected sir. This is very small, introduction. Always I get opportunity. Anish sir is consultant endocrinologist at Apollo Sugar as well as Apollo BGS Hospital, Mysore, Wellness Super Specialty Center, Mysore, MBBS and MD, Mysore Medical College, Mysore, and DM Endocrinology, TN Medical College from Mumbai. Speaker at various CMEs conferences, has been principal investigator in few clinical trials, and also member of ESI, RSSTI, DIPSI, IMA, ITS, and KES. So this is very short and small introduction to our respected and beloved Dr. Anis sir. With this, I would like to hand over this meeting to Dr. Anis sir to further navigate. And we would now invite Dr. Anis sir to set the context and start panel discussion, sir. Over to you, sir.
Thank you, Avdesh. Let me start by wishing everybody a very good evening. For the next, I would say 50, maybe 60 minutes, we'll discuss certain aspects of a molecule which is very popular, that is vildagliptin. I have 4 eminent panelists with me to take us through this panel discussion. I have Dr. Karthik Mundichidappa from Bangalore. Dr. Karthik Mundichidappa is a consultant diabetologist at the Daifa and Karthik Hospital, Bangalore. Then I have Dr. Ashwin Kulkarni, who's an associate professor of medicine at MS Ramaiah Medical College. I also have Dr. Venkatesh CR, who's assistant professor of medicine at JSS Medical College, Mysore. And the final panelist, I don't see him. But
yeah, he could not join, sir. Probably stuck. If he join, I'll just let you know, sir.
Yeah.
As
so I'll just tell you. I mean, so the fourth panelist who probably would join later is Dr. Arpit Amin. He's a physician and diabetologist working at Chittoor in 2 or 3 clinics. So probably he'll join us late. So as of now, we'll start a discussion with the 3 panelists that we have. I welcome all 3 of them, Dr. Karthik, Dr. Ashwin, and Dr. Venkatesh. Now, what we are going to do is over the next, I said 45 minutes, 50 minutes, we're going to touch on certain aspects of this particular molecule. The reason why there's so much of interest in vildagliptin is one, because of this very interesting trial called the Verify trial, which kind of gave us very interesting results. And the second reason why there's so much of interest in vildagliptin is because it has gone off patent, and you have such a wonderful molecule which is available for use at a cost which was fraction of what it was, let's say, a year back. And these are the reasons why this particular molecule has generated so much of interest among the medical fraternity. So I would like to start by asking Dr. Karthik. Dr. Karthik, what do you think? What do you think that? Do you think that combination therapy? I'm talking about combination of oral anti-diabetics has deciding on what kind of combination you use. It has a bearing on outcome. It has bearing on improving results as far as glycemic controls is concerned, and probably it also has. Does it have any bearing on the way diabetes progresses? We are talking about the way there is a decline in beta cell function. Is there something which can be done by using appropriate combinations to arrest this? So, do you think combination therapies are the way to go as far as managing diabetes is concerned?
Thank you, Dr. Anish, for my introduction and for the question also. So, we have seen there's a lot of evidence from earlier studies that show that when we go on a stepwise approach, which is a traditional way of treating diabetes, where you start off on a metformin, then you add on a sulfonylurea, and then you wait for the HbA1c to again climb up, and then you intervene. So that has been the traditional approach. And there has been a lot of studies, for example, the UKPD studies, which have shown that most of the patients would require more than one drug to treat their blood sugars at some point of time. And as the number of years go by, and when there's increasing, when the HbA1c increases. So there is a lot of evidence now, especially the verified trial, which shows that you need to intervene early. You don't need to wait for the HbA1c to climb up. So you need to add a second agent or go initially with a dual agent to to aggressively treat the diabetes and get the HbA1c under control. You need not wait for it to climb up and then intervene. So there is a lot of evidence from the verified trial suggests that we need to add a second agent as early as possible, because what it happens is it would minimize the treatment failure or the duration of the primary or secondary treatment failure also with that. So I think the best way forward was in my practice would generally not only go with metformin but try to go with a DPP4 inhibitor along with a metformin instead of a sulfonylurea.
So what you are trying to say is that the traditional approach that we've been using all these years, where we add drugs sequentially, that probably is not the right way of doing things at present. Probably it's time that a lot of us start adopting the combination therapy early on in patients of diabetes. Correct, Dr. Murthy? That's what you're trying to say, Dr. Karthik. Right. I also would like to invite Dr. Ashwin to give his opinion on this particular topic. What do you think, Dr. Ashwin? Do you agree with Dr. Karthik, or do you think that we still need to probably manage patients sequentially?
Hello, sir. Good evening, sir. I think I would completely agree with what Dr. Karthik sir has just mentioned, that we need to see the patient as a whole, and also we need to assess that there are a lot of pathogenic mechanism of the hyperglycemia. So metformin alone may not address all the issues. Maybe it is one of the best drug, and all the evidences have told that it needs to be there. So we are there with metformin. But metformin alone, we can't leave it, and we have to think of the legacy effect memory, the metabolic memory of the diabetes. So we don't want patients to be on metformin for a long time in spite of the HbA1c not getting under control. Vildagliptin, as it has beautiful mechanism of action, it will definitely help to control a lot of things. It has a lot of other advantages which we need to give to the patients. Basically, what happens is metformin, what we all have seen is it does help, but in more than 50 to 60% of patients, we don't achieve the target HbA1c with metformin alone. So I feel we should not deprive the patients of this new molecule, which has been proven with a lot of benefits. So I think we should go ahead with starting the combination therapy early in the course of diabetes.
Right, Dr. Ashwin. Dr. Venkatesh, would you like to add something to what Dr. Ashwin and Dr. Karthik just said?
Sir, usually, hello, am I audible?
Yeah, we can hear you.
Yeah, sir, I usually start with metformin, then usually add a acarbose or voglibose. And if not getting under control, then I will add a vildagliptin or some other gliptin.
Right.
Then only if I exhaust all this, then I will go for secretagogues.
Right. So essentially, what you're trying to say is that initial 2 or 3 choices are non-secretagogues, right? And only when they fail, then you think of adding a secretagogue. Correct?
Yes, sir.
Right. Now, I would like to ask Dr. Karthik, as far as Verify trial is concerned. Now, Verify trial has shown us quite emphatically that if you use a combination of Vilda with metformin right at the word go, you can achieve tighter control of HbA1c, no two opinions. You can probably, reduce the risk of, or I would say, let me rephrase it. Probably you can, you don't need to step up the therapy that often as you would have normally done when you would have used 1 or 2 drugs separately. So, I mean, do you agree with that? I mean, have you seen something like this in your practice?
Yeah.
You think?
So it's much easier to control the HbA1c levels when you go with dual therapy, and also and the patient, I don't need to wait for the patient to go through the whole phase where we need to see whether lifestyle modification is working, then metformin is working, then does it have anything to do, because we're losing the valuable time. It's because of late we also talk about glycemic variability, so we don't want to have too much of time spent above range or below range, especially above range, because it exposes the patient to that amount of that much of harm. And the greater duration of their staying above range, so the greater the likelihood of complications starting. So we don't need to wait or don't have to expose the patient to higher levels of blood sugars. And by adding a DPP4 inhibitor or any other OADs along with metformin, we can target the HbA1c much earlier and prevent the patient from having any complications also.
Right. Thanks, Dr. Karthik. Dr. Ashwin, I mean, you were talking about the glycemic legacy effect and the metabolic memory effect. Now, keeping the results of Verify in mind, do you think using early combination therapy would give that additional, I would say, a good metabolic memory to your patient, because you are able to achieve tighter controls initially right at the word go, within few weeks or few months of a diabetes being diagnosed? So do you think that's a very good approach to follow in your patients?
Yes, sir, I do agree with that. And the best part of the Verify trial is we have got a very good evidence, a very scientifically backed study to put forth this concept of combination therapy at the earliest. So I think, and also there is an added advantage of the molecule going off patent, and most of our patients are now affordable also, because we always had a concern of the affordability in our group of patients. So when we have the backing of a very good sound scientific background, and we have a good molecule which is available now easily in India and at the very affordable price, so I think we should go with the results of the Verify trial, and I think it will surely help our patients to do better in their sugar control.
Thanks, Dr. Ashwin. Dr. Venkatesh, Dr. Venkatesh, are you there? I think probably is not there.
Yes,
so
sir.
let me come. Yeah, Dr. Venkatesh, are you there?
Yes, sir.
Dr. Venkatesh, I mean, let me play the role of a devil's advocate here. Now, do you think probably looking at the data we have got with the HL2 inhibitors, especially with regards to the extra glycemic benefits, do you think there is also a point or there is also, I would say, there should also be a push towards using more of metformin with an HL2 inhibitors initially, because this is one drug which is shown to have some extra benefits? Or do you think any combination therapy would be good enough, or a Vilda metformin is good enough, or anything is good enough in the beginning when you see a patient with fasting?
Given the results of the huge trials of vildagliptin and the affordability with which the manufacturers are making it, I think it's prudent to start a combination of vildagliptin along with metformin rather than metformin alone. Wait for the glycemic control to be achieved with only metformin. So, and because they are weight neutral I think we can go ahead with this combination metformin with gliptin, preferably vildagliptin because it has good data.
Right. Now, when we talk about combinations, what do you think would be, Dr. Karthik, coming back to you, what do you think is, the hierarchy in which you choose your combinations? Let's say metformin with a gliptin, or metformin with a glyphosine, or metformin with an AGI, or metformin with pioglitazone, or metformin with SU. So what would be your first choice of a combination therapy in most of your patients? I mean, obviously there would always be certain specific indications, but let's say broadly, what do you think would be your most commonly used choice? What do you think a particular combination has an advantage over the other combination?
So basically, I would look at the clinical condition of the patient and what he presents with, and depending on his, what symptoms are, and if if the glucotoxicity is too much, in terms of HbA1c being like about 10 or even above 9, I would preferably go for insulin with OADs. But then if the HbA1c is around say 8, 8.5, or even less than 9, then I would prefer to add them along with lifestyle modification, add them on metformin with a DPP-4 inhibitor. Whereas I'm very averse to use sulfonylureas. So I want to hold that to the last. Where I would not prefer to use sulfonylurea because I believe in that school of thought which says that you don't need to whip up the beta cells and exhaust beta cells. Some people say this, that hypothesis is wrong, but I strongly believe that there is something true to that. That you would exhaust the beta cells by putting sulfonylureas early in the treatment. So it's all about preserving the beta cells. So I think we should go with a DPP-4 inhibitor and a metformin, and also carbose would benefit because it has a synergetic effect when you put it when you add it with a DPP-4 inhibitor. And that's how I would like to do that. And SGLT2 inhibitors, yes, definitely yes. But then I would first go with these 3 drugs and then think of the SGLT2 inhibitors.
Right. Dr. Ashwin, what are the combinations wherein what are the OADs wherein you are comfortable combining with vildagliptin? Is there any particular class of agents which you prefer combining with Vilda, or you think that it can be combined with all classes of agents? It has a synergistic action across the board.
Sir, as per as the data which I have read or whatever the patients which I have seen, vildagliptin was quite comfortable to add with any group of the OHAs. As sir mentioned now that the sulfonylureas, we have a lot of issues nowadays, but still I think at low dose we can still combine vildagliptin and sulfonylureas along with metformin. But especially with the weight gain, the sulfonylureas have their own and the risks and hypoglycemia. So we have to be little skeptical. But metformin, voglibose, and gliptins are excellent. But in some patients, I still sulfonylureas do have a very significant role, as we have a lot of experience with them, age-old molecule. At least in a subset of patients, I think sulfonylureas can still be used. And coming to SGLT2 inhibitors, I'm still not very comfortable using it at initial stages along with metformin itself. So I would rather prefer a voglibose or a DPP-4 inhibitor. But coming to its own advantages of cardiovascular safety, in some patients, definitely maybe a little bit after DPP-4 is what is a personal choice. It's what I feel.
Dr. Venkatesh, would you like to say something about this? Which drugs would you prefer adding along with Vilda?
Dr. Karthik told, I also avoid putting sulfonylureas in the beginning, and I advise the patients to try insulin for a couple of months, and along with metformin and lifestyle modification. I'd also prefer to add carbose or voglibose. Then going for vildagliptin or teneligliptin as of now. I don't usually prefer to use sulfonylurea right away because of the beta cell exhaustion.
Right.
Like Dr. Anish has mentioned about the legacy effect. See, in my practice, I've seen the legacy effect is much more when you put somebody on insulin, a recently diagnosed diabetic who comes in, you put them on insulin initially, along with maybe metformin or a DPP4 inhibitor, and and if you, they tend to, they would not require insulin after a few months, and then they seem to have a better control even after 10 years or even after, much longer period.
Usually they start going into hypoglycemia by the end of second month,
Right.
after adding insulin.
See, one thing is for sure that, my comment on this particular issue is that if you are dealing with a patient who has come to you with really high sugars, who's catabolic, who has a lot of weight loss, a lot of osmotic symptoms, yes, insulin is the best drug to use in that particular patient. To begin with, even a short course of insulin, 2, 3 weeks, 4 weeks, would give very good results. The sugars will come down. Patient will have very good symptomatic improvement, weight gain. All those osmotic symptoms will come down. And then subsequently, as you said, there would be a good recovery of the beta cell function because you've taken care of glucose toxicity early on, and that definitely helps. Now, as far as combinations are concerned, Vilda and metformin definitely a very good combination to use to begin with. My reason of not preferring SUs early on is more, I would say, with the fact that if you use a non-secretagogue in the initial stage, you can achieve an HbA1c of even 6.5 without causing hypoglycemia, without causing too much of disruption to patient's lifestyle. Now, when you use a SU, it's very difficult to achieve an HbA1c of less than 7 because when you try to go for a tighter control, most of these patients have recurrent hypos, and that itself will be a deterrent for patient to go on a strict diet and exercise. So if you're using combinations of metformin with maybe vildagliptin, metformin with AGI, or metformin with SGLT2 inhibitors early on, and use these drugs in various combinations for first 1 or 2 years, you can try to aim even for an HbA1c 6.5 and give good metabolic memory to your patients. So I think that's the reason why secretagogues should definitely be delegated to a third or a fourth rung drug rather than the first and second rung. In my practice also, SUs are usually, not even third, I will say usually fourth or fifth order drugs. Unless a patient is already on it when he comes to me and is reluctant to change. There are a few patients who, for cost reasons, don't even want to spend a little extra. Then it's a different story. But I would per se not start. I think that I agree on that point of view. Now, we move on to another closely related topic, that is patients who have chronic kidney disease. We see lots of diabetic patients who do have chronic kidney disease. It's becoming a fairly common problem. Now, how do you approach a patient who is developing kidney disease? I mean, like, what's your approach? What kind of drugs would you like to use? Dr. Karthik, I mean, if you have to use an oral drug, what are the choice of oral drugs you'd pick up in these patients who are developing chronic kidney disease? Somebody is falling up with you, and slowly there's a decline in the renal function. The EGFR is going up. So, I mean, going down. So what are you going to do?
Probably first I'll reassess what all medications he's on and whether any medications is causing the, his deterioration of his kidney function, and probably correct those aspects. And then coming to the diabetic drugs, probably if the metformin is, if the serum creatinine is more than 1.5, they say, some people say you need to stop metformin, but some people say you can continue metformin. There's still a gray area. So I think you can throw some light on that. And probably I would consider an SGLT2 inhibitor initially if the renal function is fairly preserved. So because that also it is known to improve the renal outcome in patients with CKD. So I will go for SGLT2, but definitely if he's on a sulfonylurea, I would stop the sulfonylurea because I don't want him to go into hypos. And if he's on insulin, probably go on to a shorter acting insulin to prevent hypos again. And a DPP4 inhibitor is preferable because it is doesn't have an adverse effect on the renal function. But only thing, we need to reduce the dose in a few molecules, and in I think one molecule you don't need to reduce the dose. So with vildagliptin, I would definitely reduce the dose and in combination with other medications.
Dr. Ashwin, what is your approach to these patients? Somebody who's falling up with you, the EGFR starts to decline. So how would you knock off the oral drugs that the patient is on, and what OADs would you like to continue?
Yes, that's what the biggest concern for this patient is a hypoglycemia. So the biggest threat of sulfonylureas has to be immediately stopped. And the safer one will be the, I think as sir mentioned, linagliptin is most favorable, and even the dose reduced vildagliptin is better. DPP4 now newer class, we can definitely use which has shown to improve the renal outcomes. So I think based on the glomerular EGFR, we can take a further call on which molecule to be used. But definitely, I would prefer linagliptin as a personal choice.
Right. And Dr. Venkatesh,
Usually,
what do you do in your patients who develop decline in GGFR? I mean, they are developing CKD and it's slowly progressing. So how do you address these patients? Would you use
Usually
vildagliptin in these
for-
patients?
I usually convince them for insulin, at
Right.
least a basal insulin, along with repaglinate. I frequently use repaglinate because it's a short-acting drug, and also glyclazide I prefer, but not in newly diagnosed patients. And as the others told, linagliptin preferable. Teneligliptin also is good, and vildagliptin, but with the reduced dose.
Right.
This is my approach, and up to 2.5 creatinine, I usually give metformin.
My comment here is that I feel that we should strongly urge everybody to stop using creatinine as a deciding factor and switch over to EGFR. Almost all of us have smartphones. We can download a EGFR calculator. Nowadays, what we prefer is a CKD, EPI, EGFR calculator. That's the one which is universally accepted. And if somebody is using EMR, probably the moment you enter serum creatinine, you will get the EGFR values. So I think the first thing we should encourage everybody who's treating diabetes is to stop using creatinine values and use EGFR values to take a decision. As far as metformin is concerned, up to 45, it's fine, but 30 to 45, probably need to use half a dose, and below 30, you definitely have to stop metformin. Surprisingly, when you start using EGFR, you will realize that even a creatinine of 1.1 in patients who are a little elderly turns out to be to have a EGFR which is like maybe 35, 40. So you have to be a little careful. That's one thing. Probably one of the best drugs to use in CKD would be gliptins, as rightly pointed out by all the panelists. The drug which we can use all gliptins. Only thing is, when it comes to Lina, you can use it across the board without dose reduction. So that way, you don't need to worry about down titrating the dose as the CKD progresses. As far as Vilda is concerned, below EGFR of 45, we prefer using a 50 mg OD dose, and above that, we can use BD dose. So that's what we normally do. And again, now till about, I would say a year back, maybe 6 months back, SGLT2 inhibitors were contraindicated when EGFR was below 45. Now, at least two drugs, that is Cana and DAPA, can be used up to EGFR of 30. And that's the advantage of using those drugs is that they slow the renal progression. They can reduce albuminuria. They can also improve renal outcomes. So as far as insulin is concerned, definitely at one point of time, all diabetics would need insulin. There are no two opinions. I mean, once the EGFR keeps going down, probably insulin would be the safest drug. But again, you have to be careful in how do you dose insulin, because again, the risk of hypos is very high, as rightly pointed by everybody. So that was about the role of OD, especially vildagliptin in CKD patients. What about elderly patients? Dr. Ashwin, what is your approach in elderly patients? Do you think that you need to have a special approach in these patients, or you can use, you can treat them just like any other patient? Would you prefer a gliptin or a vildagliptin in these patients?
Yes, sir. That's what, sir. Elderly, so we can't consider them as just a grown-up adults, because the physiology is different and aging process would have changed a lot of aspects. So we need to have a different approach. Basically, with the two things. One is the risk of hypoglycemia unawareness, those things which are most important aspects. And apart from that, the consequences of hypoglycemia, falls, coronary events. So those are the biggest challenges for us. So I feel the safest drugs which will prevent hypoglycemia are the one to be used. So in that condition, gliptins are always, they fit in all the boxes, and I feel they are the ideal ones. And based on the EGFR, maybe we can titrate the metformin. So sulfonylurea, definitely I would not advise for any elderly patient. And insulin based on their glycemic status. SGLT2 inhibitors, a little bit, we have to be, I felt we have to be more careful with regards to the UTI, which are more frequent in women and elderly. So I think taking into all these considerations, metformin and gliptins are the best choice for elderly is what I feel.
Dr. Venkatesh, your comments on elderly patients, your choice of OADs, whether vildagliptin is a good
The risk of hypoglycemia and hypoglycemia unawareness, I would like to prefer short-acting drugs, especially repaglinide and also gliptins in elderly, and small dose metformin can be given.
Right.
This is my take on it.
So what you're saying is you can use
SGLT2 inhibitors.
Come again?
I don't usually use SGLT inhibitors.
And why is that?
Usually they would have had a couple of bouts of UTI.
Okay.
Because in males, at least the risk of prostate hypertrophy is there, and females usually prolapse, etc. will be there. So I usually don't prefer to give.
Dr. Karthik, do you agree with Dr. Venkatesh as far as SGLT usage in adults is concerned? Do you use them in your elderly patients, or you're not comfortable using them?
I use a lot of SGLT2 inhibitors in my elderly patients, and it seems to work well with them. And very few I've seen, having mycotic infections of UTI. UTI is very rare, but mycotic infection, yes. But even that, with it goes away with after 1 week. If we just temporarily stop the drug and restart it, usually they do well. And it is because most of the patients have some amount of diastolic dysfunction in diabetic and the elderly, and they are, in the ejection fraction is sometimes on the lower side, most of them. And when you put an SGLT2 inhibitors, it does do wonders in terms of their heart and also controlling the sugars. Because it has a lot of benefits in terms of even their kidney function, and it's much easier to.
Right. What about gliptins? I mean, do you think gliptins are good drugs in elderly patients?
Yes, I like Dr. Ashwin and Dr. Venkatesh said, hypoglycemia is the main issue when it comes to elderly patients. One is when somebody has an hypoglycemic episode, it's very dreadful, and they may be alone. They may not have any help, so they would find it difficult to even correct their hypoglycemia. And then another issue with the elderly is falls. So you don't want an elderly person having falls for the risk of fractures, and that would open another whole lot of issues. Again, it becomes a vicious cycle. If a person has a fall, fracture, is bedridden, and is immobile, and the sugars will go up, and then again, it's very difficult to get hold of the whole situation. So in those cases, I would prefer a gliptin, probably along with metformin and SGLT2 inhibitor.
Dr. Ashwin, your comments?
Yes, sir. Exactly. I second with the comments mentioned by my colleagues. The hypoglycemia is one of the biggest problem for us. And regarding SGLT2 inhibitors, as it was mentioned, it has added benefits for the cardiac dysfunction and decreasing the cardiac mortality. I just wish I'm not sure whether how much I am correct in that, but the risk of ketosis, dehydration, I'm little skeptical in the elderly. So I think my choice for best would be gliptins and metformin based on the EGFR.
Right. So one thing is for sure that most of us agree that elderly patients, gliptins are definitely a very good drug to use, mainly because of their placebo-like side effects. One thing, and the fact that they don't have hypos, don't cause weight gain, and as you rightly said, at that age, one episode of hypoglycemia and it's quite traumatic for the patient, especially if they're alone. Coming to an emergency is a big problem. Especially, I'm sure this is what I keep telling, that for us, hypoglycemia is probably just a drop in blood glucose. But for a patient, it's a very scary experience. And more than scary, it's an experience which can be financially, I would say, quite draining, because if they end up with a corporate hospital, by the time they go out after a day, they would have spent 10, 15, maybe 20,000 rupees, because they would do all tests. Many patients will also probably have a CT or an MRI done, because they were oriented post hypoglycemia. So it's something which is definitely very uncomfortable for the patient, the whole experience, the cost involved, and coming to the hospital. I mean, that itself is something which is pretty bad. So definitely elderly patients, probably the first aim, whatever we do for the patients, is to see that we give them drugs which don't cause hypoglycemia. So definitely lower use of sulfonylureas, more use of metformin and gliptins because of side effects. And choose, if you want to use SGLT inhibitors, choose it with caution. Dr. Venkatesh rightly said there are patients who may have BPH, recurrent UTI, so you should probably be careful not to use SGLT2 inhibitors in those patients. But again, Dr. Karthik was rightly saying what we normally see in practice is more of mycotic infection. We don't see so many UTIs. But if your patient is having recurrent UTI or persistent UTI, probably it's not a very good idea to use SGLT2 inhibitor. I would not use it in that context. So that is quite true as far as use of gliptins, vildagliptin, and other such drugs are concerned in elderly patients. Now,
what is your usage?
Use in elderly patients?
Yes.
I mean, minus the secretagogues, everything can be used. I mean, metformin is good. Only thing is, as I said, if you're looking at EGFR elderly patients, even a creatinine of 1 may equate to a EGFR of 35, 30 and all that. So you have to be a little careful about that. So what I do is I use metformin, I use gliptins, and I do use SGLT2 inhibitors in these patients. I will use AGIs. But this is probably true for those patients who have short duration diabetes. If somebody has been diabetic for a very long time, then you have to use an SU, because somebody has been diabetic for, let's say, 5 years, 6 years, probably SU would be warranted, would be required in a lot of these patients. And there are a lot of patients who would also be on insulin. I have a lot of elderly patients who are on 4 shots of insulin, basal bolus, because the sugars are not under control. In fact, just recently I had this patient who's a doctor, retired doctor, and she is on basal bolus regimen of insulin, because her insulin requirements are so high that you cannot use anything else. No oral drug would help. So we can just use oral drugs to give a smooth control. Use metformin, AGIs, you use gliptin or SGLT inhibitors to probably keep a check on the dose of insulin. But it is definitely something which is required in many of these patients, especially who have long duration diabetes. So if you have an elderly patient who's been diabetic for, let's say, 10 years, I'm sure a lot of them would already be on insulin. So you have to just be careful about adjusting dose of insulin. Now, this is the last part of our talk. How do you think drugs going off patent impact management? Let's start with first Vilda, and then maybe we can talk about DAPA also. So Vilda went off patent about a year back, I think 1.5 years back. So I'm sure all of you would agree that your usage of Vilda would have definitely gone up because of the cost factors. But do you think that the generic Vilda is as good as the innovator Vilda, or do you think there is some difference? I know it's a loaded question, but let's take an opinion. Maybe we can start with in the reverse order. Venkatesh, what's your opinion? Generic Vilda versus the innovator Vilda.
Sir, I actually have used Blue Cross company Vilda. It's 3.5 rupees per tablet, and it works.
Okay. Okay. So you feel there is no difference between?
Not much difference. I don't know. Depending on the company profile, we usually rate. We don't know what is there inside.
Right. Dr. Ashwin, your opinion on this?
Yes,
you agree with Venkatesh, or you have a different opinion?
No, I do agree with Venkatesh sir, but definitely I would go with the company also, looking at the standards and their thing. So obviously we do have a slight preference for the generic molecule, but the molecules going now off patent. So I think the good companies would have maintained the good standards of production and supply. So I think we can go ahead with the products by the good and reputed companies. And I think it will help patients a lot, because still now, because of the cost effect, many of them were not able to afford. This will be definitely boon to them. Definitely, as you mentioned, the innovator with the good companies are definitely good, is what I feel.
Dr. Karthik, do you think there's a difference in your practice? That
I agree with
sometimes, a generic doesn't work and you change to innovator brand and it works better. Do you think something like that is happening, or you don't agree with that?
To be honest, I don't have an answer for that question, because I don't know any study, or I have not actually compared when putting somebody on a innovative brand and then stopping it and shifting them to another brand. I've never done that, so it would be difficult for me to answer that question. But even now, there are a lot of patients who go to the Jana Aushadhi and they pick up some generic medicines there. So sometimes it seems to work, sometimes it does not seem to work, but we really can't say unless we have a study on that.
My take is that if you have a molecule which is off patent, which is from a good, reliable company, I'm sure we can have confidence on that particular molecule. Because at the end of the day, there may be 100 brands which are selling Vildagliptin, right? There are a lot of brands which you have never heard of. I mean, there are a lot of companies which you have never heard of. So probably I'll be a little skeptical about using those brands. I would probably prefer using off-patent Vilda from a good company whose profile is good. I know that their products are good and it will work. So as far as that is concerned, I think there should not be much of a difference between innovator, a brand, and maybe this thing. But you need to choose your product properly. I think that's probably what's important. What about DAPA? Does it has that increased the usage in your practice after it has gone off patent? Dr. Karthik, would you like to answer that?
So, dapagliflozin, certainly it has impacted the way we practice. We use of SGLT2, and definitely the share of DAPA has definitely gone up. And I'm sure in everybody's practice it must have gone up, and it's working wonders, I feel. And I don't feel there's a difference between the innovator brands and the generic brands of dapagliflozin as of now. So, like, I would totally agree with you. When choosing the generic brands, it would be better to go with a reputed company who have some quality checks in place.
Dr. Venkatesh, do you think your DAPA usage has gone up after it has gone off patent, the way Vilda usage has gone up?
It has gone up, especially reputed companies who are offering at a less. The price is the catch here, nothing else.
Dr. Ashwin?
Yes, sir.
Are you using more of DAPA these days because of the off patency and the cost coming down?
Yes, sir. Since past 1 year, and also the number of prescriptions have definitely gone up, and people are also quite happy with the thing. And most, I think, advantages for the patient was the weight loss, which they have seen, which they're very happy about. And obviously sugar control and is quite good. That's what we have seen.
Now, probably one of the last questions. I mean, how do you rate a combination of metformin with a gliptin with an SGLT2 inhibitors? I mean, how do you think is it a good combination to use, and where would you use this combination? I mean, anybody can answer. Metformin, gliptin, and an SGLT2 inhibitors.
So I think it is the excellent combination, because all the possible mechanisms are targeted here, and there is no beta cell exhaustion, no risk of hypoglycemia. I think it's an ideal combination. But obviously, with each patient, checking their profiles, I think it is wise. But definitely, all the three fit into all the proper places with this combination.
Dr. Karthik, do you think it's something which should be used more often? A triple combination.
I think probably most of us would be using the combination. I mean, if not together, at least separately.
Right.
Most of the patients are on all the three drugs, and especially I think with the onset of SGLT2 inhibitors, I think it has somehow pushed the usage of insulin by a few years.
right? So you feel that.
Yeah. So I think somebody comes with a combination with one pill which has all the three medication. It would be better to reduce the pill burden also and the cost probably.
We have lots of gliptin glyphosate combinations, right? We have at least we also have a Vilda with the Remo combination. Earlier we had Lina with Ampa and Sexa with Dapa. Now we also have Vilda with Remo glyphosate combination coming in. So probably I'm sure maybe 6 months down the line we'll have a triple drug which includes all three, a single molecule. It's likely to happen. Dr. Venkatesh. I think Dr. Venkatesh. Okay.
Hello.
Dr. Venkatesh, what do you think about a combination of metformin with a gliptin with a glyphosate with an SGLT2 inhibitors? Do you think it's a good combination?
The polypill approach, it had come some time back, but I don't know why it went off. But this polypill approach is actually, it will improve the adherence of the patients, because
Right.
then you not take pill burden is reduced. 5-6 tablets in one is a preferable approach. But if it comes, we'll definitely take up.
Right. So maybe I think we have touched on various aspects of diabetic therapeutics, especially with relation to gliptins, vildagliptin. We have talked about the role of early combination therapy. We have touched on a combination of vildagliptin with other ODs and how do you combine them. We have had a very fruitful discussion on choosing the correct ODs in patients with CKD and elderly patients. And we've also had this discussion on a drug which has gone off patent. Now, probably I would like to close the panel discussion here with a closing remarks from all of you. Dr. Karthik, would you like to give a final closing remark with regard to vildagliptin? How do you see the role or the future of vildagliptin in the coming years?
I think with being off patent, I think with its increased use, and we have seen the benefits in our clinical practice, I think we should not be averse of using vildagliptin as a first line therapy also. Maybe most patients are not they're not tolerant to metformin, so we could start with vildagliptin as a first line of therapy, and then see how it goes. So I would feel that there is a lot of scope for vildagliptin for years to come.
Thanks, Dr. Karthik. Dr. Ashwin, your closing remarks on Vilda and its role in coming years.
The thing is, the biggest advantage of vildagliptin is the no side effects, almost nil side effects. Whereas compared to the SUs, which have so many side effects and hypoglycemic events, and now with the price coming down, definitely it should be the first line of choice. As of now, we have a good evidence backing our views also. So I think it definitely has a big role in the coming years as the first choice of treatment.
Right. Dr. Venkatesh? Yeah, please. Go ahead, Dr.
With the use of SGLT2 inhibitors, I think SGLT2 inhibitors increases glucagon.
Right.
Whereas the DPP4 inhibitors, it reduces the glucagon. So I think both combination together would, try to neutralize that the effect of glucagon. And
in fact, the combination of the SGLT2 inhibitors with glyphosins have shown to have lower rate of genital infection compared to using SGLT2 inhibitors alone. We have a lot of studies, we have a few meta-analyses also, which have definitely found a lower rate of infection. So yes, these two drug combination would be a good combination because of the synergistic effect on the hypoglycemia and lower side effect profile. Agreed. Dr. Venkatesh, your closing remarks on the role of Vilda in coming years.
Ultimately, the prescription pattern of Indian doctors will depend on the price.
Right.
It boils down to that. As the price reduces, we start writing the molecule.
Right.
And all beneficial effects put together with a low price, we have to take up such molecules. So I think Vilda has a good future in the near future.
Done. So I think we have had a very fruitful discussion. I would like to close here by saying that vildagliptin is a molecule which has a lot of evidence as far as the control of blood sugars are concerned. We have very good results from the verified trial, which has shown that a combination of Vilda with metformin works up to 5 years and also reduces the chance of a patient requiring up titration in therapy. So that's something which is very, very reassuring. And obviously it has very, very, I would say, almost like a placebo-like side effects. There's nothing much to worry about. For this reason, this molecule is going to be used in greater numbers in coming years. And I'm sure the use of Vilda has definitely gone up over the last 1 year after it's gone off patent. And this is probably going to increase further in the coming years. Thanks a lot, everybody. I would like to especially thank all three panelists, Dr. Karthik, Dr. Ashwin, Dr. Venkatesh, for the wonderful deliberation. Thanks once more. And I hand the session to Abhidesh for his closing remarks.
Yeah. Thank you so much, sir. Sir, with your permission, I'll go vote of thanks.
Please go.
Yeah, so we take this once again opportunity to thanks Dr. Anish Well, sir, for moderating the panel discussion, all the panelists for sharing their views on vildagliptin in clinical practice. Thank you so much, sir. And we would also thanks to all doctors who have joined us for panel discussion. And I'm sure you will appreciate the views on vildagliptin presented today. We salute to our all doctors who have contributed immensely for keeping us all safe and healthy in these challenging time. We at Alchem Laboratories will continue to serve doctors, patient by making our product available, especially Gluvilda, Gluvilda OD and Gluvilda M, which is we can find out anywhere, any corner in Karnataka. Thank you so much for your kind support, sir. Please do continue be there with Gluvilda, sir. We have a Gluvilda range of vildagliptin entire basket. So once again, thank you all the doctors for joining today webinars. Thanks a lot to all. Thank you.
Thank you. Good night. Good night, everybody. Nice meeting you all. Nice talking to you all. Bye. Good night.
Thank you,
Thank you,
sir.
sir. Good night.